Hello, everyone. Welcome to our second August webinar for the California Child and Adolescent Mental Health Access Portal, CalMAP, formerly called CAP. We now have a new name, but we're still the same group and same service. Please call us at 800-253-2103 or request the consult online at if we can show the next slide, it will be great to show our website too. The link to our website. Thank you. You can call us online, call us via phone or request a consult online at cal-map.org. We provide real-time consultation that includes clinical guidance on how to apply what's taught in our webinars to your patient care in your clinic. And also we have a new webinar program this year that offers new and more educational content than before, including a core curriculum, live webinars, on-demand webinars, and different types of project echoes. Here's a link to our new education offerings for the 2024 to 2025 academic year in chat. And one highlight of this new educational program is that we also offer on-demand monthly webinar series recordings. So if this time doesn't work for you, you can watch the recordings online and answer questions afterwards. If you get a passing score, then you're eligible for 1 hour CME and 1 hour ABP MLC Part 2 credit for each webinar you complete in this way. The other housekeeping item is at the end of today's webinar, please make sure that you either click the link in chat or use the QR code. These will be shown at the end of the webinar to claim your CME credits today, because now this is the only way for you to get the credits. So for our sessions today, the topic is common factors, building therapeutic relationships in primary care setting. My name is Hohui Eileen Wayne. I'm one of the child psychiatrists at CalMAP. I also help organize CME and educational activities along with our wonderful CME committee members. Today's webinar will be recorded and it will be posted on our website for viewing afterwards if you sign up for the on-demand webinars. If you have any questions during the talk for our presenters, please use the Q&A feature in this webinar, and we will try to save a few minutes to answer all of your questions live if possible. About our speakers today, we're very excited to have Dr. Barbara Ivins. Dr. Ivins is a psychologist and clinical director of early intervention services, part of the behavioral health division at UCSF Benioff Children's Hospital, Oakland. The multidisciplinary early intervention and early childhood mental health programs at EIS serve children with medical, developmental, and social emotional risks and challenges, including trauma. Program services are relationship-based and integrate mental health, development, and family partner perspectives with a trauma and diversity-informed framework. Dr. Ivins has worked extensively over decades to infuse early childhood mental health into all child serving systems, including healthcare, justice, child welfare, and early interventions. In addition to direct services and extensive program development, Dr. Ivins has provided training, supervision, and consultation within the Bay Area infant mental health community and within California for more than 30 years. And has written numerous articles related to dyadic intervention and integrated models of service. The other speaker, Dr. Joan, is a clinical professor in the Department of Pediatrics, Division of Developmental Medicine at the University of California, San Francisco School of Medicine. Dr. John's research interests center around innovative programs that strengthen behavioral and developmental healthcare capacity in pediatric primary care. Dr. John serves as Senior Associate Director of our very own CalMAP program. She's also the Pediatric Mental Health Care Access, the Senior Director and also the Director for our CME programs in CalMAP. She also directs the Resilience Clinic at UCSF Benioff Children's Hospital, Oakland, a primary care-based caregiver child group intervention for young children from age 0 to 5 exposed to adversity. Given the interest in time, I'm going to go ahead and let our speakers to take it away.
Eileen, let's go ahead and advance the slides. Neither Barbara or I have any relevant financial disclosures, and And going on to the next slide. These are our learning objectives for today. I think if you're like many of us here, you have no idea what common factors are. I didn't know what common factors were, but hopefully by the end, you're going to understand how helpful these things are going to be when you're holding your patients who have mental health needs in primary care. And so we're going to be learning about these skills and hopefully getting some practical tools along the way and learning how they help us to build therapeutic relationships with patients and their caregivers. We want to start further developing our trauma-informed care mindset and bring more of an authentic and non-judgmental presence with us into our clinical work so we can build more empathic and attuned partnerships with our caregivers, patients, and families. And finally, there are some brief tools or brief interventions that the American Academy of Pediatrics like to call common elements that I think will be really helpful for us as we encounter children with a range of behavioral concerns, whether or not they actually meet criteria for a diagnosis. Next slide, please. Okay, so what are these common factors? And I am drawing here heavily from the American Academy of Pediatrics mental health competencies, so they talk a lot about these. Next slide, please. So the whole motivation for this talk is this situation that I think many of us pediatricians have found ourselves in. So we are looking in vain for a qualified therapist who will take insurance and maybe even Medi-Cal and who has some availability within the next few months for our child or patient with some pretty urgent concerns. And it can feel really overwhelming. And I know that feeling of helplessness, I've been going, I know what help my patient needs, but I don't know how to get it. And how do I hold this patient while they're waiting for months and months and months for the specialty help that they need? So what can we as primary care providers do for our pediatric patients? We will bring help. Next slide. So HELP is an acronym that stands for hope, empathy, language and loyalty, permission, partnership, and plan. And these are the common factors. And again, I cannot take credit for this acronym. This comes straight to us from the AAP. So what exactly do we mean by common factors? Next slide. Okay, these are communication skills, and they are common through many different kinds of psychotherapy, such as CBT or motivational interviewing or family therapy. And when it's looked at, a lot of the reason for the efficacy for these various forms of therapy come down to these skills. Okay? And you don't have to be a therapist to offer hope, empathy, pay attention to your language, and really start to ask for permission and building collaborative partnerships with our families. We can do this too, and we can help create a therapeutic space for our patients and families as we're holding them and forming a bridge for the next stage of service. They're really helpful in building up a therapeutic alliance with our patients and their families, which in turn will foster well-being and hope. And we know how much stigma still exists around these kinds of issues, how much sensitivity, how much just the emotional journey that many caregivers and families and patients are on as they're trying to get their heads around what do these concerns actually mean. And by offering these common factors, we can help them on this journey and build this partnership, this kind of alliance that hopefully will overcome some of the barriers that we might encounter, some of what looks like maybe questions or doubts or resistance, and then help patients create this bridge for patients to go on for further care. Next slide, please.
I told Joan that I thought it would be helpful to add this graphic that was designed by parents, actually, who are part of a family accountability board and a project that we have here at Benioff Children's Oakland. And we were in conversation with them a great deal about what they want to see in their relationship with their pediatrician. So these words, this language, which is about organizing pediatric practice in the first 3 years of life around early relational health, are concepts that they came up with. And what struck me about it is how close they are to the common factors. So you can see that parents really want a primary provider who can bring their authentic self, staying consciously professional, They want someone who's able to build partnership and trust by humanizing the visit and the clinical experience and really showing empathy. And they want someone who can share information. So it's such a great alignment with the common factors that AAP is really coming up with.
Next slide, please. So the common factors were kind of developed because of our unique position in primary care. Many times people will come to us with concerns that may or may not fit the criteria for actual diagnosis, especially earlier in childhood. So these factors are what we call transdiagnostic. They're helpful across a wide range of behavioral health concerns and diagnoses, and whether or not you can actually check off the boxes to make a diagnosis. These actually serve as brief interventions. So there's times we feel like, what can we offer to our patients? We can offer these, and these are actually interventions that are amenable to primary care, and that can actually make a difference for children with mild to moderate mental health concerns. They can really reduce distress while the patient is waiting, or maybe this is all they need sometimes, and they can help address barriers for seeking care. Next slide, please. So the first common factor is hope and promoting hope. And simple statements that we may already be doing, like, I've seen kids with these behaviors improve. I've seen them doing well. And if we can get the right supports in place, and I've partnered with this person or with this agency, or I've seen kids get better with this kind of therapy, just even offering that expectation that's like, hey, I've seen good things happening. Can be a real booster for families who are maybe experiencing a lot of distress because of the concerns that they're giving to you. And the other aspect of building hope is to notice and then also name the strengths that you see in the child and in the caregiver, and elevating the strengths and the supports that they are bringing and that they are talking about, the positive experiences in their lives. So there's this balance between all the adversities that children may face on one side, and we know what they are, and we've seen what they can do. But there are all these amazing protective factors, supportive relationships, all different kinds of enrichment services and activities, various community supports, ways to promote safety in the environment, ways to build up coping strategies. These are modifiable, and these can really help tip the balance, and we can offer that hope also. Next slide, please. And another way that we can build hope is by noticing and naming the strengths that we see in the child and the family. Little successes that the child may be naming or that the family may be naming, just to celebrate that and to say, hey, this is great, and what a big deal this is. Times when the parents are doing a fantastic job of calming down and soothing that newborn as they're getting their shots, notice that. Acknowledge what a wonderful job the parent is doing, and call that out. It's a way of also building up hope. And here's some language that I've heard from various experienced pediatricians from across the board that I want to share with you. Like, what do you like being? What do you like about being so-and-so's mom? And tell me about some of the things you like to do together. Or tell me something you like about your child. And another resilience question is, what are things that help you or your family to get through the hard times or cope with stress? At Children's Oakland, we've added, I think it was the last two questions as resilience questions to our ACE screener or the Pearl screener. And so before we ask the Pearls questions, we are asking those two questions, and they've been really popular when implemented. Next slide, please.
So common factor number 2 is empathy. So empathy is really a form of kind of therapeutic listening and validation, especially when it comes in a relational context and from somebody who's, say, thought of as an authority figure for patients. When we feel sometimes like we have nothing to offer, you have to remember that slowing down and listening and being present and paying attention is really a pretty powerful intervention when someone is suffering or in some sort of emotional pain. So we have to bring ourselves in a calm, unhurried, receptive state, non-judgmental, and be available to really hear what the parent may be saying. This quote on the left is from a pediatrician, Dr. R.J. Gillespie, who was an early pioneer in addressing adversity in pediatric primary care. And he makes the point that listening is therapeutic. And that when something is speakable, it becomes tolerable. And the trauma researchers and interveners often use this term, speaking the unspeakable, and being able to kind of find a language and words so that parents really feel comfortable talking about that. The key message that you're conveying is that you are not alone, it's not your fault, and I'm here to help. And on the right, we see kind of a reframe of how we might bring a therapeutic stance to thinking about what's happening in the visit. It's not about how I can fix you, but it's a reframe to how can I understand you better? So in medicine, often we think about fixing, like the medical education is about fixing. Can I treat this with an antibiotic? Is it a surgical intervention? But this is really a different stance. And when we come to trauma, when we come to kind of emotional difficulty or mental health, we're making a bit of a reframe into how can I understand you better? So at the next slide, we're going to take a moment to listen to Brené Brown tell us. She is a researcher about empathy and validation and shame and leadership. She's made a nice animation that gives us kind of the lived experience of what the difference is between empathy and sympathy. So Joanne, let's take a look.
So what is empathy, and why is it very different than sympathy? Empathy fuels connection. Sympathy drives disconnection. Empathy, it's very interesting. Teresa Wiseman is a nursing scholar who studied professions, very diverse professions where empathy is relevant, and came up with 4 qualities of empathy. Perspective taking, the ability to take the perspective of another person or recognize their perspective as their truth. Staying out of judgment, not easy when you enjoy it as much as most of us do. Recognizing emotion in other people and then communicating that. Empathy is feeling with people. And to me, I always think of empathy as this kind of sacred space when someone's kind of in a deep hole and they shout out from the bottom and they say, I'm stuck, it's dark, I'm overwhelmed. And then we look and we say, hey, you climb down. I know what it's like down here, and you're not alone. Sympathy is, ooh, it's bad, no, you want a sandwich? Empathy is a choice, and it's a vulnerable choice, because in order to connect with you, I have to connect with something in myself that knows that feeling. Rarely, if ever, does an empathic response begin with at least. Yeah. And we do it all the time. Because you know what? Someone just shared something with us that's incredibly painful, and we're trying to silver lining it. I don't think that's a verb, but I'm using it as one. We're trying to put the silver lining around it. So, I had a miscarriage. Oh, at least you know you can get pregnant. I think my marriage is falling apart. At least you have a marriage. John's getting kicked out of school. At least Sarah is an A student. But one of the things we do sometimes in the face of very difficult conversations is we try to make things better. If I share something with you that's very difficult, I'd rather you say, I don't even know what to say right now, I'm just so glad you told me. Because the truth is, rarely can a response make something better. What makes something better is connection.
So I think she does a beautiful job of kind of showing us how to be with someone, and really remember that graphic I showed you about what parents wanted. This is a really great example of how to humanize the connection through empathy. Okay, next slide. So we're at common factor number 3, language and loyalty. So in the language side, this is about not just using the same language as the patient or caregiver, being careful with your choice of language, not to use clinical language or jargon or words that parents might not understand, but to also remember that language can hurt or heal. So your choice of how you describe something, if you're describing a difficult condition, if you're describing something, you always remember that I'm painting a picture with my words, and I can affect how a parent feels about their child. So the power of that language, if you use clinical language too much or describe a set of symptoms to a parent, you're putting that kind of view of a child kind of into their space of their relationship with their child. And so you want to be very careful about that. And I would also say this about writing notes. I always believe that you write a chart note with a language that has a parent sitting on your shoulder, because parents will access their charts. And so you want to remember that how you describe the positive things that you say about the child and what you see is really kind of vitally important. So be careful about language, be careful about what you think is understood, like a word like co-regulation, for instance, which we talk a lot about with infants, may actually be jargon and not really understandable to a parent. So you want to slow yourself down and be very, very careful to pace yourself and use a language that makes sense, putting drops of information into the space. Loyalty is about how you show your commitment and support. You're conveying an attitude of I will be there for you. And remember that what the parents wanted when they said is to humanize that experience. So I think of a parent who told us that her pediatrician had made a referral to another clinic and literally said to her, let me walk you over there and make sure that this really connects for you. And she was so struck by that sense of feeling the loyalty from that pediatrician. She cared enough about me to take that extra step to really connect me in this very personal way. So very powerful as common factor. Next slide.
The last common factors, I'll start with P to round out our HELP mnemonic. And the P stands for permission, partnership, and plan. And there's another P in there that I think gets implied, which is patience. So it's really powerful to ask for permission before tackling especially sensitive issues and delving into the problem solving. For example, if it's okay with you, I'd like to ask you about XYZ, right? Partnership is a lot like the loyalty, but saying that let's work on this together, and then proceeding then to co-develop a plan with the patient and family. And the 10-part plan is not what we're after here, because that can be overwhelming, but to decide together with the family, what are the top 1 or 2 priorities and what are 1 or 2 steps that they can take to take a step closer to that goal. And then to keep moving on in this kind of stepwise way in follow-up visits, which will hopefully be sooner than a year from now. Next slide, please.
So we're going to talk about how to hold the therapeutic mindset, remembering what Joanne said at the beginning. This is not about how to become a therapist. It's about what can be therapeutic. So let's start with a poll. And the question we're saying is, how comfortable are you talking with families who are sharing emotionally charged events or challenging behaviors? This is a point in time. Nobody will see your answer. So you've got 4 choices. Where are you right now in the continuum of comfort for how you feel about this? So pick your answer and Rita will show us our results in just a second. Be honest. And Rita, when you think you have enough responses, let's see who we are as a group. This is really about what you think is in your wheelhouse right now and where your kind of comfort zone lies. Okay, here we go. This is good. So about 1/3 of the people are already really, really comfortable. About half, a little over half, are trying this but frustrated. Okay, we kind of want to hear more about that. And some people not sure, but nobody in the room is saying don't ask me to do it, which is really great. Excellent. Okay, let's move on to the next slide. Thank you. Okay, so reminding us what a trauma-informed perspective invites us to do. So we've seen a version of this before. Don't try and fix it, try and understand it. This is another way of shifting our understanding, particularly if trauma shows up in your patient population. I don't know how many of you are using the ACEs screens or thinking about social determinants of health, but that really can be seen as inviting a conversation by even using the ACEs screen. You're kind of conveying this is an acceptable topic to bring into our relationship and into our visit. A trauma-informed perspective, though, invites us to shift from thinking about what is wrong with the child to what has happened to this child or caregiver. And that, again, is a mindset shift because we've all been trained a little bit in a disease model, and we're looking a little bit for what's wrong so we can fix it. And that's just part of the training. So this is a tweak. And this is really saying we may see behaviors, we may see difficulties, but our understanding of that is not going to be what's wrong judgment. It's going to be, okay, what's happened to this caregiver and how do I have that inform my perspective? Okay, next slide. Sorry, next slide. Yep. This is just showing you, I think there's another bullet point there that didn't show up. So there's some evidence that really supports this idea that attuned communication is really important, that research about careful listening and high levels of empathy rather than a quick reassurance or normalizing something is really what makes parents feel heard and connected to their provider. Next slide. Okay, Mr. Rogers is my go-to because I work with young kids, and he had a remarkable innate talent about really connecting with children and their parents. And here's a quote from him where he said, anything that's human is mentionable. Anything that is mentionable can be more manageable. When we can talk about our feelings, they become less overwhelming, less upsetting, and less scary. The people we trust with that important talk can help us know that we are not alone. I feel like he's talking to all of us. And if some night you want to really look something up, go to YouTube and look up an old Mr. Rogers episode. You can see him talking to kids about the assassination of John Kennedy, about divorce, about disability. He could really take on any topic with such humanity and make it really mentionable and speakable. So Mr. Rogers always has a go-to. Next slide. So I'm going to introduce you very briefly to a tool called the FAN, which stands for Facilitating Attuned Interactions. The FAN was designed by people at the Erickson Institute in Chicago, and it was really designed around creating an intervention for fussy babies. So babies in the first 6 months of life who really have difficulty with fussiness and regulation, are crying constantly, difficult to soothe, and create a great deal of distress for their parents. But this tool that they came up with that was really meant to be intervening there became something that was adapted to help healthcare providers, and really most people who intervene think about how to provide attuned care for patients and families. So let's take a look in the next slide at what the FAN actually is, and I'm going to walk you through this. So here is the graphic of their tool. I want to say right now that there are wedges of core processes in this tool, but they are not designed to be linear. They describe a kind of processes of attunement and the kinds of things that might be happening in your visit. So in the center of this FAN is the parent's concern. So parents may come in with their own concern in your visit. You actually may have concerns in the visit. The providers may have concerns in the way too that really live there. So the wedges of these FAN are core processes about attunement. The one on the left, calming, is the one for you. So it really speaks to the idea that when you engage in a visit and you walk into a room, you have to have a certain amount of calm, present, focus. And there may be a lot of things going on for you when you come into that room. You may have just left another visit. You may be thinking about things going on in your own family or at home. You may have just heard some sort of news. So the idea is that that will be picked up in the room, and that you need to have a ritual, a way, a breath, where you center yourself as you go into that visit. So that first wedge is really for you. The next wedges on the top describe where the parent might be, and inside the wedge describe your strategy for what you might do in that situation. So briefly, we'll go through them. If the parent is expressing high levels of emotion or affect, then you are practicing these empathic skills that we just talked about. Empathic listening, empathic inquiry, validating their feelings, amplifying positive feelings. This is where your empathy skills are going to kick in. And really, if a parent is in high levels of affect, we know this from brain science, If you go right into information giving, they're just not hearing you. So you've got to hang out in that feeling place for a little while until you can make the bridge to really moving somewhere else. And a parent will often show you, after being empathetic and listening and validating their experience, you'll see that they're ready to move. So when a parent is ready to be in figuring it out, let's think about this together. Let's figure out this problem. That's building partnership with parents when you're in this kind of thinking mode with them. And you're using what we think of as collaborative exploration as a strategy. You're asking a set of questions. What do you think might be causing this? What have you tried? Let's kind of think about this together and understand this child together. Capacity building is what you're doing when parents are in kind of doing mode, where they're focused, they're ready to change, they're ready to take in the information. And sometimes you can build these strategies in the moment. So let's say you do have a fussy baby in your office and you're talking to the parent about what they've done. And you've heard the parent say, you said, I heard you say that she really liked to be swaddled tightly. So how would it be with you? Gaining that permission, how would it be with you if we tried it out right now? Let's take a look together and see how that works out. So there you're kind of joining the parent, you're using information they've given you, you're adding a little bit of your own information, and you're kind of modeling, let's try this together. We're kind of partners in this, building trust. And then the final wedge is what we think of as reflecting. And for the parent, like taking away their aha moments, what have they learned, what are they taking away, and trying to make a space for integration. And the idea of using this process, you could be bouncing around into all these wedges, is that the outcome will be increasing the parent's confidence, strengthening their relationship, and promoting healthy development. Next slide. So the FAN people also give us what they call the arc of engagement in a visit. Remember, this is about attunement. And I kind of love the way they lay this out, because they start you before entering the room. Take a look. How are you feeling? How are you doing? Can you take a breath? Are you organized? Who's in the room? Who am I going to see? Do I know this family? Is this a well-known family to me? A new family? What am I expecting? So you have a kind of pre-visit ritual that you're going through in your head. And then during that history taking period, you're really attending to what has it been like for you this week or since I've seen you last to be this transparent? How are things going? So this is where you're starting to check in. In the middle of the visit, are we getting to what you wanted to get to today? Like really inviting in that relational way. Have we gotten to your urgent concern that's on your mind today? And at the end of the visit, as you kind of wind down, leaving a minute or two or more to say, let's talk about what you're taking away, what was most important for you today, what might be 3 words that you would use to describe your child right now. Let's kind of summarize. And I like this idea of integration and reflection, because we know what's important also in parenting is to build reflective capacity. So you're kind of modeling that in this visit if you use the kind of arc of engagement. And then afterwards, a moment to yourself. How am I now? How was that? What did that go like? What did I learn from this visit and can take with me? Okay, next slide. Mental health talks a lot about parallel process. In that a little quote there from Julie Paul and Maria St. John, what we call the platinum rule, do unto others as you would have others do unto others. The idea here is that as humans and in a relational frame, we always work in a kind of parallel process. We treat people intentionally the way we would want them to treat others. So when you have a parent and child, you are consciously thinking about this. I want to make sure that I'm treating this parent the way I would want them to treat their child. I'm going to help co-regulate the parent. I'm going to help notice and validate feelings. I'm going to help use kind of notice positive, what we call angel moments. You're kind of modeling the behavior that you want to see and really intentionally understanding that how you live in the head of that parent can translate into how they are with their child. Next slide. So takeaways for a therapeutic mindset or a therapeutic stance: notice and amplify what is going well. Provide psychoeducation. This is your information in small doses. We think of it as drops. So always be mindful of that. Offering developmental guidance by wondering and being curious rather than necessarily just telling. Being able to observe out loud, notice, again, you're developing observational skills, you're developing reflective capacity, being curious about what's happening there and say, oh, I wonder what that means when he does that. What do you think's going on? Partnering with parents, I love this, do with, not do to or do for. So that idea of let's sort this out together, let's partner, don't take over all the time, and don't do to somebody asking permission. This is where that really shows up. When needed, co-regulate, tolerate and contain negative feelings with calm. Okay, co-regulation is big with parents and little babies. I often think of development as that movement from co-regulation to self-regulation, but really throughout our lifespan, we're needing to find that balance between co-regulating, and even as adults, we need co-regulators in our life when we're under a lot of stress. So you may be functioning in that role, and when that's needed, absolutely step in that direction. Hold hope, common factor number 1. Very, very important. Bring a non-judgmental, empathetic stance. See the child the parent sees. So you may see a different child in the room when a parent is describing, but you need to step in that empathetic way to try and see, what is the parent trying to tell me about that child? What do they see? What are they experiencing? How can I help by stepping into their shoes? The kind of Atticus Finch from To Kill a Mockingbird, I think, had that famous quote, you can't know another person till you've walked a mile in their shoes. So remembering that therapy is a bit of a journey, it's not necessarily an answer, and that as a pediatrician or a family practice doctor, you can create a therapeutic mindset that was going to be really, really helpful to parents. Next slide.
Wonderful. I always learn a lot from Barbara hearing her talk, and I feel like there's definitely a lot that we medical doctors can learn from, and nurse practitioners, I should say, can learn from our therapist colleagues. So I want to move the next part of the conversation onto something that the American Academy of Pediatrics calls common elements. And that goes along with the common factors from this same mental health competencies policy statement. So what exactly are common elements? So just as common factors or communication skills that kind of cut across multiple different kinds of therapy, common elements are brief behavioral interventions that come from some kind of evidence-based therapy, but that can apply to kind of a related set of concerns, such as anxiety or behavioral problems, impulsivity, or low mood. And like the common factors, they are transdiagnostic, meaning they don't really have to tie to any particular diagnosis. And you don't necessarily need a DSM diagnosis to start whipping these out and using them and helping kids who have like truly distressing kinds of like concerns. There are some like what we think of as complementary or integrative medicine approaches built in, mind-body approaches, stress management approaches built into some of these common elements. And the great thing is that they were really kind of pulled out and named because they are very usable as brief interventions in primary care. Next slide, please. So here are some examples. And we are talking about these through all our other webinars. For example, if you went to our webinar 2 weeks ago on anxiety, you would have heard about graded exposure, gradually increasing exposure to the thing that the kid is afraid of so they can't avoid it forever. That's a super important brief intervention or common element that we can use for kids who are showing some signs of anxiety. Rewarding that brief behavior, but also using things like deep breathing or progressive relaxation or other relaxation strategies to help kids who are facing stress, sleep problems, worries, all kinds of like related kind of cluster of concerns. And finally, guided imagery, especially through some of the apps that are available, can be helpful. Then there's this whole big bucket of behavioral concerns, kids who get labeled as oppositional or defiant. They are often kind of showing that they have an unsolved problem or they're having some issues in that relationship with their caregiver. So these are great brief interventions that we do talk about more in other webinars, but I just want to briefly name here. Just spending one-on-one quality time, positive time with your parents, or special time is what we call it. The power of undivided parental attention that's scheduled, that's sacred, that really helps to reestablish connection between that parent and child. Of course, a lot of us like to use praise, catch them being good, right? Or like little rewards for positive behavior. That's kind of done in a consistent way. And likewise, when there is an unacceptable or kind of negative behavior, to enforce those limits in a very consistent and calm way with as little drama as possible. And finally, like coaching children in naming and understanding their emotions. And that is a skill, and that's something that we can start teaching kids really young. And finally, with flow mood. And we talk about this in our depression webinar, also prescribing pleasure, telling them, go do something social, go do something fun, figure out something that can distract you in moments of high distress, that can get your mind off of those things. Some people love to journal or to write, and just like some sort of learning of like social skills, like, or other kind of like problem solving techniques for those problems that just seem to be really naughty that are causing some a little bit. Next slide, please. Okay, so some of these mind body or mindfulness based tools include deep breathing, progressive muscle relaxation, or guided imagery. And they're good for a lot of different things, everything from the sleep problems and stress and trauma and anxiety. Attention problems can also get better with this. And to the degree that challenging behaviors arise from difficulties managing big feelings, can help with the behavior problems too. And this comes from a colleague saying, hey, as she's doing the lung exam, that's a great time to say, take a nice deep breath, and showing how to do it, having them do a couple more times and saying, how did that feel? Doesn't that feel good, right? There are ways to build this in to what we're already doing in the office that can help provide what Barbara talked about as little drops of psychoeducation, those small teachable moments that we have. Next slide, please. Okay, how do we teach mindfulness to kids? These are some of the things that we do in the Resilience Clinic, which is our program at Children's Oakland for kids with ACEs. And a great way to teach deep breathing to young children is by blowing bubbles, right? They have to take a nice deep breath and then blow out slowly to get a lot of bubbles out. And it's such a fun activity to do. Parents and kids together, it's a great bonding kind of time. Another way to teach mindful breathing for kids is to have the kid lay down, put a stuffy on their stomach, and then watch that stuffy slowly go up and down, and you can kind of control the rate at which that stuffy is moving up and down. But it's a way of helping to draw kind of mindful attention to your breathing in a way that's kid-friendly. And there are lots of great children's books I'm about to show you on the next slide. These are some great books that we give out as part of the Resilience Clinic. And these are ones that have specifically been mentioned by parents in their focus groups and interviews afterwards, and saying, our kids like these, or we use these all the time. And the Mood Flip book, I think it was on Amazon for $12, not that I'm advertising. It's like the front page shows like a feeling, a face with a feeling, and it labels that feeling. And the back of the page gives you a bunch of strategies to use when you're feeling that way. And one parent said that their kid put this book in the front of, near the front door, and they would run and grab it and give it to whoever they thought needed it in the moment, and they would use it themselves. The Angry Octopus is a children's book that teaches deep breathing and guided kind of progressive relaxation skills. And I've heard of kids as young as 3 learning how to do this by following along the example of the Angry Octopus in the story. And finally, Holden Pot is very much about a story about modeling, what parents model for their children, and also the importance of not just holding all those big feelings in, but being able to find ways to let things out little bit by little bit before you just blow. These are great books, but there are many others. And even in just other storybooks, whenever there are feelings there, to take a moment to stop and say, how is this character feeling? How might you feel? Just as practice for like naming and recognizing emotions and how you might respond. Next slide, please. Okay, I talked a little bit about special time or time in, and this is one of my favorite brief interventions in primary care because it takes all of 5 minutes to explain, but it can make a real difference. And I found that for kids with kind of behavior that does get labeled as like defiant or oppositional or non-compliant, this often helps to lower the temperature in the house, maybe decrease the frequency of that parent-child conflict, and maybe decrease the intensity of the parent-child conflict, just because it's helping to reestablish some connection. And that connection is reestablished because the whole idea behind the special time is that the parents and kids are enjoying each other's company, right? So the nuts and bolts of this is that you schedule. It might be 10 or 15 minutes a day, and it might be 7:15 to 7:30 every day. But in that time, it's one-on-one undivided parental attention. The child gets to pick the activity, just nothing involving a screen, right? And it's judgment gets checked at the door, instructions really get checked at the door. It's not about, oh, no, you're supposed to do the puzzle this way, honey. This is really about having fun together and enjoying each other's company. And I think of it as money in the bank. Every time you have to scold your child or tell them, no, you have to do it this way, that's money out. Right? Every time you have to correct them or that kind of that disciplinary sort of action, that's money out. This is money in. And this connection really forms the foundation for a child's motivation to try harder or to try to do something different. It is hard for any of us to change behavior, but this is where the motivation comes from. Is that connection, that relationship. Next slide, please.
So I love this quote. It comes from the Circle of Security people. Joanne's going to put their link in the chat for you. Circle of Security International is a kind of parenting model that's based on attachment theory. They have a beautiful graphic called the circle, which really makes attachment theory very user-friendly, but they have reduced this idea of everything I need to know about being a parent in 25 words or less, which I really love. Always be bigger, stronger, wiser, kind. I can't tell you how much I've used that and said that to parents. And if you really take a moment and think about what it means to be bigger, stronger, wiser, kind, it does really sum up what you really want. Whenever possible, follow your child's need. Whenever necessary, take charge. And I just love that they've reduced a really complex array of thinking about how to be a parent into 25 words. So we wanted to share that with you. I literally have given this kind of flyer to parents to put up on their refrigerator. And if you go to Circle of Security International, you will find some handouts that are free to you to download and use as you wish. Next slide.
I want to go back to our earlier question about, okay, so we are dealing with some pretty intense, like emotional, behavioral concerns, mental health issues in primary care. And I think our jobs are changing, and I think our understanding of what our jobs are needs to evolve as child health is changing. And so what is our role in providing mental health care in primary care? So this is a public health pyramid, and at the base is what we call primary prevention. This is universal for everybody who walks in through our door. Vaccines are probably the prime example of this. And I have got more Neil Rojas quotes for you, developmental behavioral pediatrician from UCSF. He said, parenting support is the closest thing that we have to vaccines in behavioral pediatrics, right? And this is a lot of what we do, our reach out and read, our like encouragement to like around positive parenting pearls, right? Universal health promotion. Now, the secondary layer of this is early intervention. When we're first discovering developmental delay, when we're first discovering some parenting stress or ACEs or other big stressors in the home, or hearing about these behavioral concerns that might be, just kind of like a little bit more extreme end of the normal, or might be something emerging, right? So we can provide some targeted interventions here to help address those early concerns, reduce the stress level, and figure out what's going on. This is where screening tools really come in. And again, the rest of our CalMap webinars are going to be talking a lot about the specific screening tools and how we can use them. But a lot of the brief interventions that we described here, whether they're the common elements or the common factors, they can really serve as some of this early intervention to strengthen parent-child relationships, because this really is a foundation for mental health for that child going forward. And we can prevent a lot of bad things from happening by being there early and addressing these concerns early and providing the right conditions for that mental health or healthy mental and emotional development to continue in a much more, robust and thriving kind of way. Finally, the top part of the pyramid is the tertiary prevention or treatment arm. And I would say this is where most of the CalMap webinars sit. How do you diagnose and treat those DSM diagnosable conditions, right? And, increasingly, we as primary care providers are being called upon to identify and treat ADHD, anxiety, depression, and a range of other common behavioral health concerns. And this really is an important part of our job. And part of the reason why I'm here, because there just are not enough specialty mental health providers to go around. And these conditions are just so common. 20% of American kids, okay? That's the prevalence, 20%. We can't outsource 20% of child health concerns in primary care, and that's why we need to learn how to do it. But today, I wanted to talk a little bit more about those first two rungs, that prime prevention, the secondary prevention, say, this is a really important part of our job, and this is something that nobody else does. Because by the time they go to the specialty mental health provider, they are definitely in the top part of this pyramid. Next slide, please. Okay, I'll say this and I'll get off my soapbox. Okay, so what's our job as primary care providers for kids? We are not therapists, but we can be therapeutic by using the common factors and providing help and using these brief interventions or common elements. And by having this sort of like trauma-informed, attuned mindset that Barbara was describing earlier. Okay, we are not psychiatrists, but we can learn to diagnose and treat the common behavioral health conditions so the kids don't have to wait forever and a day to get the help that they need. And we are pediatricians and we promote health. And there is a lot of prevention and promotion we can do by strengthening that parent-child relationship. We can really set kids on this much healthier path for the rest of their lives. Okay, so with that, I'll get off my soapbox and we'll take any questions that may have come through, if any have come through.
Thank you so much. Thanks for the fantastic talk, Dr. Ivins and Dr. Jeung. This is so informative and at the same time fun and heartwarming. It's just so nice to hear about this topic. I feel like there are a lot of questions in the beginning of the talk, but they were already answered during the talk when you were speaking. I do see that there are a few questions in the queue, and the first one is Dr. Grant shares she had learned about behavioral activation through these lectures and calling the console line, and they have been very useful, especially with teens. Thank you for sharing that. It's nice to hear that. And then also a question coming from Dr. Grant. Do our speakers have any suggestions on how to provide both hope for parents while also trying to have them understand the chronic conditions in a realistic way?
This is a great question. And I think this is like where trying to create like a balanced sort of conversation is really helpful. So when we create a more empathic space, I think we invite the questions, right? The questions that parents may be holding in their head. And when we're able to name and identify the strengths, I think it then becomes easier to hear about what some of those limitations might be. And so that's some of the general thought that I have. But I think people want to hear the truth from us too, and want to hear what kind of like, you know, what the evidence might say. But I always like to end with like some kind of like hope and some sort of plan, and how do we keep moving the needle? Because a child is still growing, child is still developing, and there's a lot that we can do. And Barbara, I'd love to hear your thoughts as well.
Yeah, I have two thoughts about this question, Darcy. Thank you so much for that. One is that parents are always helped by other parents. So if you are in a practice or a position where there are parent support groups around, or other parents who have children who have the same chronic condition, I've seen parents help parents through difficult times more than anybody. My second thought about it, I think a lot about the difference between population health approach and an individual medicine approach. And I feel like even with a chronic condition, the path and trajectory is going to be different child to child. So I think holding hope is really about making sure that you're aware of the successes, even how small they may be, of this children. This is working, this medication is working, the OT is really helpful, they're doing a great job. And just really focusing on the relationship. How can you find a way for that parent-child to have pleasure together? Like, I would be leaning into that. What do you like to do together? I've seen children who are really, really involved and say, the parent will say, well, bath time is really moment where she really calms down and it's really fun and we have a good time, and you want to lean into those moments. Those are my thoughts.
Yeah, and then we have the next question from Dr. Jin. For a busy primary care practice, how do you find time to implement interventions for mental health problems? And how much time will be ideal, be more realistic to recommend for a visit? Also, I wanted to have a follow-up on this question. Is there any guidance or recommendations that you can give to people who work in primary care and also mental health, how to take care of their own burnout and vicarious trauma?
Those are great questions. I'll take the first one. How do you find time to implement interventions for mental health problems? Some of this is what you can do individually, and some of this has to operate at the practice level, right? So what we can do individually is try not to do everything at once, rely heavily on follow-up visits. And so we can only take a bite-sized chunk, right? And that's probably what the family can handle in a moment anyway. And so prioritize, and maybe prioritize somewhat ruthlessly, and offer like this 1 or 2 drops. We can't pull out the whole tool set every single time, but maybe if we kind of have an idea of what that tool set is, we can maybe pick and choose the 1 or 2 that we think might make the biggest impact in the moment. The other thing I loved hearing from Barbara and from some of my psychologist colleagues here is that this is a mindset more than a technique. Some of this is really about cultivating that attuned and empathic mindset. And I think that is also a muscle to be developed. And the fixing impulse is like so very, very strong. I know it's very much trained in it, as it's a hard one to kind of keep in check sometimes, because I want to fix everything with that 10-part plan, and realizing that's a little bit too much, right? It's too much for the time that we got, and it's too much for the family to hold all at once. So to prioritize and to realize that who we are in the space matters probably as much as what we say and what we do. And to lean into a lot of follow-up visits to follow up on a lot of these other concerns as they come up. The other part I think is structural. A, we need teams, and B, we need time. So really advocating hard with our healthcare systems for that multidisciplinary team in primary care. We need integrated behavioral health providers. We need care coordinators. We need folks who can provide the therapy within the context of primary care. And we cannot hold this all by ourselves, right? So we need the teams, and we need time. I say 15 minutes is really too short for a mental health visit. 15 minutes was designed for a couple of shots, or for strep tests and antibiotics, or an ear infection. That's really what it was designed for. It was designed for a time when primary care was very different than what it's turned into. And I think the most advanced practices are allowing you to add patients to complex care registries, and then automatically giving those kids back-to-back visits. So they get anywhere from like 30 to 40 minutes, depending on the length of your visit, for that visit, whether it's for their complex healthcare needs or for their behavioral healthcare needs. And I know it exists, I know it's possible, but it takes a lot of work to make that actually happen. So this, I think, is where primary care is going to go. Barbara, I don't know if you have some additional thoughts to add to that.
I'm going to add one thing to what you said. I would say know your downstream referrals. As I run a program that is a downstream referral source to a primary care practice here at the hospital and also in our community, and cementing those relationships where you know you have, if you have a mental health stream. I've also been in rural communities where that's really not an option and there isn't a workforce, and it's you. So I think your message about check in frequently, check back, is really important, like convey that you have interest. And I wanna say in our last 30 seconds about the vicarious trauma situation. In mental health, we really believe in a kind of reflective consultation model where you always have somebody to talk to, and that it's kind of built into the workflow that you have peers or supervisor or somebody, so that the same thing, be able to speak the unspeakable. It's okay if you're overwhelmed. Go find a place to really say, walk into that back room, say something to your colleagues like, wow, that was a lot for me to take in, and really feel okay about yourself. It's human to feel that way. It's completely natural. Self-care, your self-care, that calming wedge, how you take care of yourself, really important. Thank you for bringing that up.
Thank you both so much. We're at the top of the hour. Just wanted to share with all y'all that please use the link or the QR code to claim your CME credit for today. We now offer a new education program, new webinar program. So now we do have webinars on the 1st, 3rd, and 5th Thursdays of the month. Our next webinar will be on August 29th on the topic of Intro to Assessment, including measurement-based care and interprofessional collaboration by Dr. Stein-Buchel. Thank you so much. We'll see you in 2 weeks.